Welcome, everyone, to this Premium Revision Explainer. If you're looking to absolutely master clinical medicine, you are in exactly the right place. Today, we're setting the stage for a world-class medical education session, and we're focusing entirely on one of the most critical neurological presentations you are ever going to encounter: epilepsy. We're going to break down the pathophysiology, the clinical presentations, and of course, those life-saving management protocols you really need to know. But hey, before we get into the mechanisms, I want to quickly highlight that today's high-yield clinical breakdown is brought to you by Durkat Premium Revisions. They're basically your ultimate resource for exam-ready studies, comprehensive courses, and practical OSCE stations. They're completely dedicated to elevating your academic performance and giving you the exact clinical skills you need to confidently prep for real-world exam situations. Okay, let's dive right into this. Here's our masterclass syllabus to build your knowledge step by step. We'll start with understanding epilepsy and causes, move into classifying seizure types, then explore diagnosis and differential. After that, emergency management, long-term treatment, and finally, we'll wrap up with the key exam takeaways. All right, starting off with Section 1, Understanding Epilepsy and Causes, Defining the Disorder. So right off the bat, we've got to clearly distinguish between a single seizure and the chronic condition of epilepsy. Now, a seizure, that's a transient episode. It's a temporary spike of abnormal, excessive, and synchronous brain activity. Think of it kind of like a sudden electrical storm in the brain. It's actually a phenomenon that affected historical figures from Julius Caesar to Theodore Roosevelt. This storm can alter movement, sensation, or consciousness. But epilepsy, that's the whole chronic neurological disorder itself, characterized by recurrent, unprovoked seizures. Physiologically, this happens when there's an imbalance in the brain's neurochemistry. You've got increased excitatory glutamate activity, so excessive neuronal excitation, combined with reduced inhibitory GABA activity. That lack of inhibition is literally what allows those abnormal electrical discharges to spread like wildfire. And guys, the scale of this disorder is just massive. To put it into perspective, it affects approximately 50 million people worldwide. While it can hit at literally any age, it's particularly common in children and older adults, and we see a significantly higher prevalence in low and middle-income countries. So what actually triggers this whole cascade? Well, the etiologies are incredibly varied. We can see structural causes, right, like a traumatic head injury, a stroke, or a brain tumor. There are genetic causes involving inherited syndromes or specific gene mutations. Infections like meningitis, encephalitis, or HIV-associated brain infections are major culprits here. But, and this is absolutely crucial, don't forget the metabolic causes. Things like severe hypoglycemia, hyponatremia, or uremia can easily spark these electrical storms. And sometimes, despite all our best investigations, the cause just remains unknown. We classify that as idiopathic.
Moving on to Section 2, Classifying Seizure Types, Focal versus Generalized.
Now that we understand why it happens, let's look at how it presents clinically. The fundamental anatomical difference here is all about where that electrical storm actually starts. Focal, or partial seizures, begin in just one single hemisphere of the brain. Generalized seizures, on the flip side, begin simultaneously in both hemispheres. This anatomical difference is huge because it dictates everything about the patient's physical presentation. When you're evaluating focal presentations, your key distinction is the patient's level of awareness. In a focal aware seizure, the patient's consciousness is preserved. They might have some motor twitching or sensory symptoms, but they totally know what's happening. Now, in a focal impaired awareness seizure, consciousness is altered. You might see them staring blankly or exhibiting these things called accommodisms, basically unconscious repetitive movements like lip smacking or hand rubbing, and that's usually followed by post-seizure confusion. Finally, a seizure can start focally in one hemisphere and then spread to involve the other, and we call that a focal to bilateral tonic-clonic seizure. Now, looking at generalized seizures, these are usually highly recognizable. The classic tonic-clonic involves a sudden loss of consciousness, body stiffening in the tonic phase, followed by that rhythmic jerking in the clonic phase. But I want to specifically call out absence seizures right now. This is a super high-yield exam topic, especially for pediatric cases. These present as a brief loss of awareness, often just a blank stare lasting maybe 5 to 20 seconds, and it's very common in kids. We also have atonic seizures, which are a sudden loss of muscle tone, causing really dangerous drop attacks, and myoclonic seizures, which are just sudden brief muscle jerks. Let's jump to Section 3, Diagnosis and Differential, the patient journey. Understanding the chronological flow of a seizure is absolutely vital for your history taking. Before the seizure, the patient might experience an aura. These are warning signs like a strange smell, visual flashes, sudden fear, or this really intense sense of déjà vu. During the active seizure, depending on the type, you might see limb jerking, eye rolling, tongue biting, or incontinence. But just as crucial is what happens after. This is the postictal phase, and it's characterized by confusion, drowsiness, a severe headache, or even this fascinating phenomenon called Todd's paralysis, which is a temporary localized weakness. So this chronological history is basically step one of your diagnostic investigations. Blood tests help rule out those metabolic causes we talked about, but your two most crucial tools are the EEG and MRI. The crucial point here is that the EEG, or electroencephalogram, is your primary tool to detect that abnormal electrical epileptiform activity. However, when you're looking for structural abnormalities, like a tumor or a previous stroke, an MRI is always preferred over a CT scan. All right, Section 4, Emergency Management, First Aid and Status Epilepticus. Okay, I need to guide you step by step through the management of status epilepticus, because this is literally a dire medical emergency. We define this as a seizure lasting 5 minutes or longer, or recurrent seizures without the patient recovering consciousness in between. Step 1 is always the ABC approach: secure the airway, breathing, and circulation. Step 2, provide immediate treatment. Administer oxygen, gain IV access, and check blood glucose to correct hypoglycemia if it's there. For Step 3, your first-line pharmacological defenses are benzodiazepines. We're talking IV lorazepam, IV diazepam, or bucomidazole if you just can't get an IV line. If the seizure still persists, Step 4 brings in your second-line drugs like IV levetiracetam, IV valproate, or IV phenytoin. But what about immediate, on-the-ground first aid? Let's vigorously debunk some really dangerous myths right now. When a patient is seizing, do protect them from injury and turn them onto their side into the recovery position once it's safe and the convulsions stop, just to protect that airway. Do time the seizure. Remember that 5-minute mark for status epilepticus. But do not restrain the patient. And absolutely, under no circumstances, do not place anything in the patient's mouth. The whole myth of swallowing the tongue is completely false, and putting objects in their mouth will only cause severe dental trauma or create a major choking hazard. Keep it simple and keep it safe. Now for Section 5, Long-Term Treatment, Pharmacological Management. Now, what's really interesting about this slide is how we can chunk these dense pharmacological facts for optimal exam retention. You must anchor these specific drug associations in your memory. Sodium valproate, great for generalized and focal epilepsy, but watch out for the side effects: weight gain, hepatotoxicity, and high teratogenicity, meaning you absolutely have to avoid it in pregnancy whenever possible. Carbamazepine is super common for focal epilepsy, but beware of a severe rash called Stevens-Johnson syndrome. Ethosuximide is incredibly specific. It is the absolute drug of choice for absent seizures, and only absent seizures. Finally, levetiracetam is wonderful because it has very few drug interactions, though, a heads up, it can cause irritability and mood changes. Finally, Section 6, Key Exam Takeaways, High-Yield Summary. Seriously, lock these bullet points into your memory because they are your absolute must-knows for passing medical exams and providing excellent patient care. 1. Status epilepticus over 5 minutes is a massive medical emergency. 2. For diagnostics, EEG is for electrical activity, but MRI is preferred for structural brain abnormalities. 3. Ethosuximide is the go-to for absent seizures. 4. You must avoid sodium valproate in pregnancy due to that high teratogenic risk. And 5. Clinically, when a well-controlled patient suddenly comes in with a seizure, remember that poor medication adherence is actually one of the most common causes of breakthrough seizures. Understanding epilepsy isn't just about passing an exam. It's about confidently managing a complex condition that profoundly impacts people's lives. And as neurotechnology rapidly advances, we really have to ask ourselves, will pharmacological management eventually be replaced entirely by targeted brain implants that just stop these electrical storms forever? It's a crazy thought. But the learning doesn't stop here. Durkout Premium Revisions is expanding, and bigger, better content is on the way. I highly invite you to explore Durkout's new video tutorials for continued interactive learning. Just search and follow Durkout Premium Revisions on TikTok